So this recording is for drugs for the respiratory system as well as drugs to treat infectious diseases. So the first condition we're going to look at is asthma. And if you look in the top right, you've got two panels there. The one on the left is of a bronchial and associated structure under normal condition, and the one on the right is during asthma. So if we look at the one on the right, what we see here is we have a bronchial, right, which is made of smooth muscle, and the smooth muscle diameter is controlled by both the parasympathetic nerve as well as the sympathetic nerve that's not shown. So what happens is the parasympathetic nerve decreases the diameter, whereas the sympathetic nerve can increase the diameter of the bronchioles. You can see under normal condition, you've got submucosal glands and you've got goblet cells, both of which secrete mucus. The epithelium and the basement membrane of the normal bronchiole looks very well organized. And you can also see here that you've got alveoli in clusters at the end of the respiratory bronchioles. And it's at the level of the alveoli that the actual gas exchange occurs, and then the air is then transported through the respiratory bronchioles and the bronchioles in and out of the lungs. There's also mast cells, and so we'll look at mast cells in the light of asthma and what they do. And as you can see, as you go further and further into the bronchial structure, the amount of cartilage decreases and the amount of smooth muscle increases. All right. So in asthma, what happens is that you've got smooth muscle constriction, and you can see over here, right? And you can see over here that really in asthma, what happens is there are two things. So first of all is that the immune system is activated, and secondly, these magical mast cells degranulate. And what happens with degranulation of mast cells is basically that the cell membrane of the mast cells disappear, and then it releases whatever contents are found in the mast cells. And you can see here the contents that are found in the mast cells act to attract white blood cells, so neutrophils, lymphocytes, eosinophils, and act to also cause changes in the bronchial supply, the vascular supply of the bronchioles. So you can see it causes vasodilation, and it causes increased capillary permeability. The other thing that it does is it also causes bronchospasm or bronchoconstriction, right? Other things that happen is that the goblet cells and the submucosal cells become hyperactive, and so you can have mucus accumulating and mucus actually forming a plug. And when mucus forms a plug, that means that there's limited air going in and out of the bronchioles into the alveoli. And sometimes what happens is the alveoli can actually hyperinflate because air is more easily enters into the alveoli, and it's harder for air to actually go out. Right. So what we want to do and then the other thing that happens is because of the immune activation and the cellular infiltration is you've got inflammation happening. Okay, so the goals of therapy for asthma is to basically reverse acute episodes of asthma, prevent and control asthma episodes that are recurrent, because in a large proportion of people with asthma, they have persistent asthma, whether it be severe or mild or moderate. And then, of course, just to actually reduce the underlying inflammation of the bronchioles and associated hypersensitivity. So we're going to look at that in the following slides. So again, this is a very different same information, just looks very different. But again, what you see here is you can see an allergen triggers mast cell degranulation. And with mast cell degranulation, what happens is you've got the release of mediators, right, which attract inflammatory cells to enter in, and also attract inflammatory mediators to cause inflammation. At the same time, the mediators are also responsible for causing bronchospasm. And it's the combination of the bronchioles constricting and the inflammation within the bronchioles that cause less air to actually flow into the bronchioles, into the alveoli. Right, and the inflammatory response also causes what's considered bronchial hypersensitivity or hyperreactivity. So, the drugs to treat asthma involve the following. First of all, you've got glucocorticoids, right? And what glucocorticoids do is they basically reduce the amount of inflammation that's possible. Right? We also have mast cell stabilizers. So what mast cell stabilizers do is they stop degranulation. And if you imagine, if you stop degranulation, none of the following things would actually happen. Right? The third group of drugs is bronchodilators, and Beta2-Agonists are the main group of drugs for this. And what bronchodilators do is they reverse the bronchospasm, right? So these are three groups of drugs that are used to actually treat or manage asthma attacks. So one of the big things with asthma is because it's a respiratory condition, it's better for those drugs to be inhaled, because there are several advantages. First of all, I'm going to draw a very sad looking person there. If you inhale the drug, and their lungs right over here, if you inhale the drug, what happens is the drug basically goes straight through to the lungs, right? And so you've got relief of acute attacks is rapid because it goes straight in to the lungs. And because it goes straight through to the lungs, it means that it doesn't have to go through the systemic circulation, right? Compared to oral, when it actually has to be digested, absorbed, and then go through the systemic circulation, drugs that are inhaled go straight through the target site. And because they go straight through the target site, it means that therapeutic effects are enhanced with a smaller dose, right? And it basically minimizes the risk of systemic adverse effects. So there's three different types of ways to administer drugs by inhalation. The most common one is metered dose inhalers. So these are typically called puffers. So basically 1 or 2 puffs, wait 1 minute between puffs, but it requires lung-hand coordination. So it requires the person to be able to control when they actually depress the puffer and when they actually inhale, right? Even with the best of techniques, only 10% of dose given through a metered dose inhaler actually reaches the lungs. And so what happens is aero chambers or spacers can be used to increase the amount of drugs that is delivered to the lungs. Right? Dry powder inhalers, the second type of inhalation technique, are breath activated, so 20% reaches the lungs instead of 10% with the metered dose inhalers, and it doesn't require hand-lung coordination. Right? Nebulizers basically convert a drug solution into a mist, which is inhaled via face mask or mouthpiece. So again, it doesn't require hand-lung coordination, but it takes a little bit longer to actually deliver the same amount of drug contained in one puff from an inhaler. Now, what do we do when only 10% reaches the lungs? As I said, one of the ways to increase this amount that actually reaches the lungs involves the use of spacers or aero chambers. So what we've got over here is we've got the proportion of drug that goes to various different places without the use of spacer. Right? So without the use of spacer, 10% of the drug basically stays in the inhaler device in there. 81% of the drug stays in the mouth and throat, and then only 9% is actually found in the lungs. With the use of a spacer, less basically ends in the mouth and throat, and about double the amount ends up in the lungs. And again, because the spacer contains this aero chamber, a larger amount of drugs is actually contained within the inhaler device. But the important thing with the use of the spacer is that, number one, you've got more drugs actually reaching the target site, and you've got less drugs actually staying in the mouth and throat, right? And this is especially important when we're looking at glucocorticoids. So the first drug we're going to talk about is mast cell stabilizer. So the mast cell stabilizer stops degranulation and stops release of the mediators, right? Because it doesn't allow the mast cell membrane to actually break up and rupture and release everything that's contained within it. So some examples of mast cell stabilizers are cromolyn and nadocromol, right? So what happens there is it basically binds to the surface of the mast cells to basically stop the mast cells from degranulating. So basically, it reduces inflammation and it reduces bronchospasm. So over here, you've got just the uses of mast cell stabilizer, and just note here that they have no direct bronchodilator effect, and really these mast cell stabilizers are used only prophylactically, right? So once the mast cells degranulate, you can't use a mast cell stabilizer, because it's like bolting the gate shutting the gate after the horse has bolted, right? So it needs to be used as a preventative measure, because again, once the mast cells have degranulated and release all these mediators, it won't actually stop the process. It's effective only when inhaled. It's got poor GI absorption and it's rapidly excreted. So again, this is the purpose and the mechanism of action of the mast cell. Moving on, we're looking at glucocorticoids, and as I said, glucocorticoids basically inhibit the inflammatory response. So you decrease inflammation, right? And basically when you decrease inflammation, you decrease bronchial hyperactivity, right? And you decrease the amount of inflammatory mediators, you decrease the infiltration of inflammatory cells, and you decrease basically the airflow limitation. All right. The unfortunate thing is that it may increase the number of, it may also increase the number of beta receptors and their responsiveness to beta-2 agonists. And remember, these beta-2 agonists are the ones that cause bronchodilation. So it may actually cause the beta-2 agonist to actually work better. All right. Glucocorticoids are the foundation of asthma therapy. Most effective anti-asthma drugs, and again, because we're trying to control the underlying inflammation, it needs to actually be used on a fixed schedule. So it can't be used to reduce inflammation during an acute asthma attack. It needs to be used as a preventative measure to reduce chronic asthma. So you can see over here, it's not used to abort an ongoing attack, but it's used to reduce the overall inflammation during times when there's not an asthma exacerbation. Usually administered by inhalation, and it's very important that it is administered by inhalation if at all possible, because it minimizes systemic adverse effects. But in some cases where it's not, where it's better to actually give IV or oral doses, then those are also available options. So you've got over here just the differences between glucocorticoids when it's inhaled versus when it's orally administered, right? So inhalation should be the route of choice. So very effective, much safer than the systemic glucocorticoids. And because you can see here, it's a lot safer because it's devoid of serious toxicity even at high doses. So you can see here a couple of effects of adverse effects of inhaled glucocorticoids is fungal infection of the mouth and throat, and dysphonia, so hoarseness or difficulty speaking. But again, that can be minimized with either gargling after each administration of the inhaled glucocorticoids or using of the spacers to actually decrease the amount of glucocorticoid that basically is in the mouth and throat, right? If you go back over here, if you actually use a spacer, instead of having 81% of the drug administered stay in the mouth or throat, it actually goes down to about 25% of that, to a quarter of that, to 22%. And it means that the risk of hoarseness and of a yeast infection, fungal infection actually goes down. Now, oral glucocorticoids is also an option, usually with moderate to severe persistent asthma, and there is potential for severe toxicity. And so again, orally administered glucocorticoids should only be used for periods as briefly as possible, and only when symptoms can't be controlled with safer meds. And the safer meds are inhaled glucocorticoids and inhaled beta-2 agonists. And we'll look at beta-2 agonist as we go on in this. So why should the oral glucocorticoids be used for as brief a period as possible? Because it's been linked to adrenal suppression, and we'll talk about that in the next slide. It's been linked to osteoporosis, to hypoglycemia, peptic ulcer disease, and more importantly, in children and adolescents, it can slow the height of the child or the adolescent, right? Just slow it down so that the child doesn't grow as quickly as they would had they not been taking oral glucocorticoids. So this is just an example. This is just a slide illustrating what happens during adrenal suppression. So let's look at what happens normally. So in the diagram on the left, you've got under normal conditions. You can see here that stress will stimulate the hypothalamus to release corticotropin releasing hormone, which then travels to the anterior pituitary to release ACTH. ACTH then travels to the via the systemic circulation to the adrenal cortex, and the adrenal cortex releases cortisol, which then causes biological effects. Now, under stress, what happens is the amount of CRH increases, which then increases the amount of ACTH, which then increases the amount of cortisol, right? So this is what happens normally. Now, what you can see over here as well is you've got this dotted line, which is a negative feedback system. And what this negative feedback system does is it acts as a brake to reduce the amount of CRH and ACTH and cortisol released if it gets too high. But again, under stress condition, that stress increases CRH, ACTH, and cortisol. Right? Now, for a person who's taking exogenous cortisol in the form of glucocorticoids, what happens is the exogenous glucocorticoid will actually activate this negative feedback system. And so what happens is exogenous corticoid will cause a reduction in CRH and will also cause a reduction in ACTH and will cause a reduction in endogenous cortisol released. Right? And this is at a time where usually stress would normally cause an increase in cortisol. Right? So the presence of the exogenous glucocorticoid, exogenous glucocorticoid leading to a decrease in endogenous cortisol through this negative feedback system, this is called adrenal suppression. Where is it? Right, so this is called adrenal suppression. And that's not good, because then what happens is that it can be fatal, right? So high levels of glucocorticoid are required to survive severe physiological stress, such as systemic infection, trauma, or surgery. If not, it can be fatal. So what happens is, because this adrenal suppression occurs when patients are who are taking exogenous glucocorticoids are under stress, they must be given increased doses of oral or IV glucocorticoids to actually make up for that lack of increased endogenous cortisol. Now, there is a way to actually get rid of this negative feedback system, and the way to do it is to slowly discontinue treatment. And so you can see over here, if you discontinue treatment, it must be done gradually. And also, this recovery of the adrenal cortex causing a release of endogenous cortisol may take several months, right? And so as the adrenal cortex function is slowly recovering, patients have to be given supplemental oral or IV glucocorticoids when they're actually under severe stress, until the endogenous cortisol release is back to normal. Third group of drugs used to treat asthma are the Beta2-Adrenergic Agonists. And these Beta2-Adrenergic Agonists mimic activation of the sympathetic nervous system. Firstly, in the bronchial smooth muscle, but also if the dose is increased, then it becomes non-specific and it starts having effects on the heart, right? And also skeletal muscle. So let's look at that. So just some example of Beta2-Adrenergic agonists are albuterol and salmeterol. And they can be either inhaled or they can be oral, right? If they're orally administered, then they're long-acting. If they're inhaled, they can either be short-acting for quick relief, or they can be long-acting for long-term control. All right, so again, what this does is it reverses bronchospasm, and so it provides symptomatic relief, but it does not affect on inflammation, no effect on the release of the infiltration of inflammatory cells, and no effect on the release of inflammatory mediators and other mediators as well, right? So again, if a person with asthma is taking a bronchodilator, they should also be taking glucocorticoid to actually have an effect on all these. So again, mechanism of action is on the bronchial smooth muscle to promote bronchodilation. And the adverse effects, if you see here, are all systemic, right? Even with inhaled effects, with inhaled PrEPs, you can see here that the adverse effects are systemic, centering mainly on the cardiovascular system, as well as tremor of the skeletal muscle. And again, with oral PrEPs, because it goes straight into the systemic circulation before it gets into the respiratory system, there are potentially cardiovascular effects as well. So again, just to actually reiterate, you've got short-acting beta agonists that are inhaled and long-acting beta agonists that are also inhaled, right? And so this is the rationale for taking short-acting beta agonists to abort or stop an ongoing asthma attack, to prevent exercise-induced bronchospasm, and to actually stop a severe acute attack in its tracks when the person is hospitalized. Although when the person is hospitalized, it's usually via a nebulizer rather than a metered dose inhaler. Long-acting beta agonists that are inhaled are for long-term control, so fixed schedule, not PRN. So again, this is given to basically control and to promote bronchodilation throughout the day. And when used to treat asthma, it must always be combined with a glucocorticoid. And so you see down here, you've got the combination of the glucocorticoid and the long-acting beta agonist over here, right? So this glucocorticoid long-acting beta agonist combination, not recommended for initial therapy and not indicated for long-term maintenance in adults and children. Moving on, we're going to look at allergies. And again, with allergies, what we have here is we have allergies as being a hypersensitivity reaction. So it involves the production of the antibodies IgE, right? And then over here, upon secondary with primary exposure, you also have degranulation of mast cells. You have release of primary and secondary mediators, and that causes bronchial edema, that causes infiltration of leukocytes, that causes mucosal secretion. So very, very similar to what happens during an asthma attack. And so you see over here, the drugs that are used for managing allergic rhinitis is basically very, very similar to the drugs used in managing asthma attacks. And they are glucocorticoids, they are mast cell stabilizers, and they are, instead of beta agonists, we actually have alpha-1-adrenergic agonists. Right? So two of the 4 drugs that are used to manage allergic rhinitis are similar to those used to manage asthma, and then the other 2 are different. All right, so the first one that's different are antihistamines. So antihistamines basically block the effects of histamine. And you can see here it doesn't reduce nasal congestion and is effective if taken prophylactically. So if taken before the allergy system, and should be taken regularly throughout the allergy season, so that it can actually prevent histamine receptor activation. All right. One of the big side effects with antihistamines is sedation, but again, there are second generation antihistamines that are available on the market, and that has a lot less sedative effects than the first generation one. And then you also have some anticholinergic effects such as dry mouth, constipation, and urinary hesitation. Now, the other lot of drugs that are used for allergic rhinitis that is not used for asthma attacks are a different type of sympathomimetics. And in this sympathomimetic, it basically activates alpha-1 adrenergic receptors on nasal blood vessels. And what these alpha-1 adrenergic receptors do is they cause vasoconstriction of the blood vessels in the nasal passages to decrease edema and that stuffiness of the nose. And you can see here that it can be either intranasal or oral. And again, there might be rebound congestion only with oral intranasal use. And with both intranasal and oral use, there is a chance that it will actually activate other sympathetic receptors that are found in the brain, so it can cause CNS stimulation, and also sympathetic receptors that are found in the heart to cause a stroke and other cardiovascular effects, and it also has the potential for abuse. Drugs that are used to control coughs are antitussives to suppress the cough, expectorant to actually eject the cough, and mucolytics to actually make the mucus more watery. And you can see here with the antitussives, you've got opioids and non-opioid antitussive, right? So what the opioid antitussives do is they actually make it harder for that person to actually cough by elevating the cough threshold in the CNS. And you can see here, because they're opioid agonist, what happens is it can also lead to respiratory depression, and it also, because they're opioid, it has significant potential for abuse. However, I should say that the doses used for opioid antitussives is a lot lower than those doses used for opioids as an analgesic. There are non-opioid alternatives as antitussives, and so you've got dextromethorphan. But again, this is a very good antitussive that doesn't contain opioid, and you've got here just the adverse effects of those drugs, sedative and anticholinergic properties. An expectorant, another group of drugs that are used for cough, basically makes it easier for the mucus to be ejected from the mouth and nose, and may require some higher doses to become effective. And then mucolytics react directly with the mucus to make it more watery. So again, so it's easier to actually eject from the respiratory tract. Now, common cold. What we see here is that the common cold is an acute upper respiratory viral infection, and really there's no cure for it, just treatment of symptoms. And so most common colds are treated with over-the-counter cold remedies, and most cold remedies are combination cold remedies that contain two or more of the following, right? Nasal decongestion, antitussives, analgesic for the pain, antihistamines, and then caffeine to actually offset the sedative effect of the antihistamines. If a child has a cold, there are pediatric over-the-counter cold remedies, but again, you have to use with caution in young children, right? So again, with young kids, especially even kids as young as 6, you need to actually make sure that you use only pediatric medications, to use the measuring device, discontinue medication if the child's condition gets worse or doesn't improve, and then avoid using antihistamine containing products to sedate children. And that's it for the moment, and I'll continue on with another recording.